In predicting an outcome for data in electronic health records, decisions have to be made about which set of predictors should be included in the model. This lecture helps you think through the selection of predictors. This brief presentation was organized by Dr. Alemi and is narrated by Yara Alemi. If you have the right variables, you can predict anything. And luckily, in an electronic health record, we have hundreds of thousands of variables. So some of them are definitely the right variables. In this section, let's discover how you determine which predictors are the right variables for your model. There are many different types of predictors available in the electronic health record. One could use diagnosis, treatment, or medications in predicting outcome. Or one could use patient characteristics like address or gender. Even vital signs can be used. There are hundreds of thousands of potential predictors in the electronic health record. In the past, we've primarily relied on diagnoses, or in other words, the patient's history of illness, to predict their various outcomes. In predicting mortality of patients within 6 months, medical history was more predictive than laboratory values or physiological markers. For example, in predicting 6-month mortality from heart failure, a patient's diagnosis was more predictive than their heart ejection fraction. Their diagnosis was also more predictive than chronological age in predicting whether or not they would die in the next 6 months, which makes sense because it doesn't matter how old you are, but what illness you have. Like we said before, diagnoses are also more predictive than laboratory values. Many lab values can be easily controlled through medication. For example, a hypertensive patient may show as normal if he has controlled his blood pressure through medications. Still, in the creation of a predictive model, there are thousands of diagnoses to consider. Historically, scientists have relied on clinicians to select a set of variables known to have an effect on the outcome of interest. However, the approach that we prefer uses all of the diagnoses available. This does lead to the difficult situation where the model is made with thousands of predictors. However, it has the major advantage that no relevant pieces of information are missing from the model. In predicting mortality, models that rely on all diagnoses without grouping them into categories have proven to be much more accurate than models that are selective in their approach or that break diagnoses down into homogeneous categories. In statistical modeling, for example in regression equations, a common practice is to discard predictors that rarely occur. The logic is that these rare predictors occur too infrequently to make a difference for an average patient. However, in the electronic health records, this isn't advised. In electronic health records, we have thousands of rare predictors. Ignoring one has a negligible effect, but ignoring thousands of rare predictors will have a large impact on the accuracy of predictions for the average patient. Furthermore, ignoring these predictors will reduce accuracy in subsets of patients who are experiencing these rare diseases. Therefore, we don't recommend that rare predictors should be excluded from the model. This yields statistical models with thousands of variables, most of which occur in rare situations. But the model will be accurate, though difficult to manage, as there are so many variables. Still, if the choice is between accuracy and ease, we would prefer to take the accurate route. A related issue is whether or not we should keep obvious predictors, or things in which the prediction task is trivial. For example, predicting whether or not a patient with diabetic neuropathy has diabetes. There's no real need to predict if the patient has diabetes or will develop diabetes in the future. After all, diabetes is already in the name of the disease that the patient is reported to have. Obvious predictors should be kept in the model for two reasons. One is that errors in these cases will lead to clinicians ridiculing the model and abandoning its use. It is important not to miss the predictions in obvious cases, and by deleting these clues, you make it harder for the computer to remain accurate in obvious situations. The second reason is this. In the electronic health record, crucial information may be missing. Obvious predictors can sometimes adjust for this situation. In our example from before, it may be that the patient is hospitalized for diabetic neuropathy, but they have no diabetes on record. After all, diabetes is usually observed in an outpatient setting. It's possible that the doctor who sees this patient does not use the same health record as the hospital records. As a consequence, this piece of information is not available in our records. Keeping obvious predictors helps the system address missing information. Statisticians are also concerned with the use of variables that occur after an outcome to predict the outcome. On the surface, such predictions look tautological. For example, if we want to predict whether a patient will develop diabetes, then all complications of diabetes or consequences of diabetes are tautological predictors, and they should not be a part of the analysis. In contrast, if we are trying to detect whether a patient has already developed an illness, then these variables are very important. For example, we could detect diabetes by its consequences or its complications. Let's say a patient with undiagnosed diabetes or diabetes not previously reported in an electronic health record can now be detected by seeing if the patient has complications of diabetes, such as renal illness or our previous example of diabetic neuropathy. Detection and prediction utilize different sets of predictors. In predictive models, we are looking forward to establish risk of future events. In these models, only predictors that occur before the outcome should be used. In detection, we are looking backwards to see if a diagnosis was missed. And in these models, diagnosis before and after the outcome of interest can be used. When evaluating predictive models, the practice is to divide the data into two sets, training and validation. The parameters of the predictive model are estimated in the training dataset, but the model is tested in the validation dataset. In the training set, all diagnoses are included as predictors of an outcome. That means that diagnoses that occur after the outcome or before the outcome are included in estimating the association between the predictors and the outcome. In testing or in the validation dataset, we no longer have the luxury of including variables that occur after the outcome is known. Here, we want to rely only on predictors that occur prior to the outcome. Therefore, it is important to exclude any diagnoses that occur after the outcome. This information is available in the electronic health record, but not in real life. In real life, we are attempting to make a prediction about the likelihood of an outcome before the outcome has occurred. Therefore, we would not have access to any diagnoses or other information that occurs after the outcome. Sometimes the available data seems reasonable, but should be ignored in the context of our analysis anyways. Even though the data is correct and nothing is wrong, it should nevertheless be ignored. For example, if we are studying the impact of treatment on survival, one must drop complications of treatment from a multivariate analysis. Including these variables will distort the estimated impact of treatment on survival. In electronic health records, complications are diagnoses that occur after treatment. Diagnoses before treatment are considered medical history, and at the same time as treatment are considered comorbidities. But diagnoses that occur after treatment are considered complications. Therefore, the statistical advice requires us to drop some of the diagnoses from our model and retain others. Here we see an example where, because a patient had an infection and was overweight, a large dose of antibiotics were prescribed, which distorted the microbes in the patient gut and led to the patient developing diabetes. If we kept diabetes in our multivariate model, then the effects of antibiotics on survival would be distorted. In these situations, we want to keep the comorbidities, i.e. the fact that the patient was overweight and had the infection, but not the complications from treatment, which in this example was the diabetes. Diagnoses and medical history, with some exceptions, are some of the best predictors to include in the analysis. This has been the lecture on selecting the right predictors for your own model. Thank you for listening.